Welcome everyone. My name is Liis Kukkonen and this is Practitioner's Viewpoint. In this series of podcasts, I will be interviewing practitioners from different fields on how they see sedentary behavior and promotion of physical activity in their work. We will share good practices about the promotion of physical activity from around the world. Today, I have the honor to introduce my guest, Dr. Mary Kennedy. Dr. Mary Kennedy is a physical activity and nutrition specialist, researcher, writer, and coach. Dr. Kennedy is a Postdoctoral Research Fellow at the Institute for Nutrition Research at Edith Cowan University. Her research focus is integrating exercise and nutrition into standard healthcare practice. Mary has served on the American College of Sport Medicine's Exercise Medicine Education Committee and is currently the Physical Activity Advisor for the American Institute of Cancer Research. In her doctoral research, she has been studying the implementation barriers to integrating exercise as medicine in oncology. She is also passionate about coaching people to run their first marathons. So in this episode today, we are going to mainly talk about how to integrate physical activity as part of patient care in cancer treatment. I am happy to introduce Dr. Mary Kennedy. Welcome.
Thank you. It's a pleasure to be here.
I'm so glad you're here today. So, Mary, let's start with your professional background. How or why did you get interested in nutrition and physical activity?
Yeah, so my undergraduate degree many years ago was in exercise physiology. And I can remember the day I had an internship experience. I was in Boston and at the Joslin Diabetes Center. And it was there that I first really saw the magic of exercise, where you could use it to actually help somebody manage their diabetes. And sort of before that, it had always been kind of seen. I had thought about it from sort of a make people feel, fit into a dress or something. And I didn't love that, but it really, watching it as part of healthcare really got me so excited. And that's really, I set out on, my path to make exercise a career sort of from a healthcare point of view, and continued into working I was at the Be Well Center at Beth Israel Deaconess Medical Center in Boston, where we were an exercise clinic that served the employees of the hospital, but also we really had this vision of doing chronic disease self-management plans, so helping people use exercise as medicine. And that's where it started, and I really have just continued along that path. Nutrition, I went to get my master's in nutrition because I saw that you can't really do exercise without also understanding the other side of that equation. And so having expertise in both has really helped me, but I still continue to be dedicated to seeing both of those as a necessary part of the healthcare system.
Great. And what are the projects that you are involved now?
Yeah, so really, as you mentioned, my doctoral work was about focusing on putting exercise as standard care into a cancer care center here, and I'm currently in Western Australia. And in my postdoc, I'm continuing that work. So really, the expertise I gained through the PhD was the implementation science side of things. So having worked in the exercise and nutrition fields for many years, and having the practical side of that, and seeing the real life challenges of making those things part of the healthcare system, I became interested in the field of implementation science, which actually studies how you put things into practice. And so married the expertise together to really look at how we can we say exercise is medicine, but how do we do that in practice? So that's what I'm really focused on right now, as well as some other research projects.
Okay, we will be talking about the implementation a lot today. I'm really looking forward to it because I think we can see it like throughout, even though we're going to talk about oncology and cancer care today, but I'm quite sure that we see this throughout medical fields, the barriers. And you have also said that there is a huge gap between what we know and what we do when it comes to exercise and nutrition. So I think it's also on a personal level and also on the organizational level that, we know a lot. We don't maybe do everything according to what we know. So why do you think this gap exists and how could we bridge it?
Yeah, I think it's such an important question. And I think there's, separating exactly what you said, the personal level and the organizational level have two different sets of challenges related to them. And I don't think we do a good job, first of all, of separating those. In looking, from the exercise and cancer perspective, we tend to say, why aren't people exercising? Well, they're not motivated. That, all of those things that come along. They don't know how to do it. But there's a lot of access issues that are inherent in the organization. And if you look at the literature, there's not a lot of people looking at the organizational level and saying, hey, why aren't the leaders of hospitals funding these programs? Why aren't there spaces for people to do it? They're two different issues. And really being clear which set of barriers you're trying to overcome is the first step so that you know what problems you have to solve. They talk a lot in the implementation science field about the idea that there's a few things. One is we tend to try to solve everything with education. So, patients aren't exercising. What they need to do is know more about exercise, or doctors aren't prescribing, same thing. But if you really start to investigate the problem, often they might know that they should be exercising, but they don't have transportation to get there. Sometimes it's, or parking is a problem. Something very simple that you can overcome, but we're trying to solve the wrong problem by just putting education at everything. And education is a necessary component of most strategies, but it's not enough. It almost is never enough to just tell people what to do. There's often something else that's included. And there's a term in the implementation science field called Islagiat, which stands for "it seemed like a good idea at the time," which is a lot of like, why did researchers put together this, exercise program? Well, the researchers sat in a room and it seemed like a good idea. So what I think we don't do enough of is that true stakeholder needs assessment. So not just asking the patients, but looking at the patients and the environment that they're in and understanding the challenges at both. Because the reality is behavior doesn't happen in a vacuum. There are things we want to do and we're challenged to do them by our environment. And so, back to what you had said before, at a personal level, there's the environment around you that might be challenging that people have to understand. And that's the same with organizations. Organizations also have sort of environmental barriers that you've got to understand to know what levers you can pull and how to make change.
Do you think that we need to analyze these barriers to be successful in implementation, or, for example, exercise? Do you think that these barriers should be analyzed individually for every organization, or how do you see that?
Yeah, that's a great question. Context absolutely matters. What's going to work for my organization in Australia is going to be different for your organization. And that's true. However, in one of the publications I'm really excited that will be available shortly is I did a scoping review of the barriers to exercise and took this social ecological approach, which really looks at sort of the individual and the environments that they're in. And I did it within a healthcare context. So what are all the layers in a healthcare context that may play a role in stopping exercise, in being a barrier from exercise being integrated into care? And what that does is really outlines the fact that there are barriers at every level and that those barriers are interrelated. So you can't solve one without understanding the others. And so your question, do we need to do it at each level? Yes, every context is different. However, I do think like that paper can serve as a place, as an outline for people to say, okay, these are probably going to be the big issues. Let's investigate these issues within my context. So you're not walking in with a blank slate. We do have a good understanding of common reasons why these things don't exist. How financial barriers happen for me will be different than they happen for you. And so we need to understand what the specific things are and who the key players are in our own environments. but knowing that financial barriers are probably going to be an issue is helpful. So I think there's a general roadmap that people can start to use to apply to their own context. And that's the work I really am interested in doing, is trying to provide that roadmap for people.
Yeah, I'm really happy that this the implementation mapping protocol is going to soon be available, and maybe also on the other fields people can use this as a roadmap, as you said. So you were talking already about the barriers that you have seen in your work, and when I was reading your papers or publications, I was some things I could expect being there, but the others were a bit like of surprise to me. So, for example, the gym hours not being enough, or transportation. So, what were the main barriers, and what was maybe surprising to you also?
Yeah, the thing is, all of those. I think what was surprising. I'm trying to think of the best way to answer this. For me, the idea that it really came down to leadership, organizational leadership, was something that I just kept coming back to, because it's the leader that really is the gatekeeper to all of those decisions. So the gym hours obviously are decided for lots of reasons. And in the case that you're talking about, we evaluated a program that had been existed for a while. Everyone loved it, which was what was interesting. You talk to patients that loved it, the doctors loved it, but it was one of those things that got to be on autopilot. And I actually think it's a big challenge with exercise and nutrition when we talk about it as part of healthcare. We've gotten to a place, and over my career, I would say that I've definitely seen the shift where we no longer really have to educate people that exercise and nutrition is important. Doctors know it, but it's a nice to have. It's not a need to have. And they don't necessarily know how to do it. So they're happy to have it as a thing. Like, oh, great, we have an exercise clinic, we can refer to it. But nobody owns that the same way they would if there was, if the, nursing staff stopped having hours that were convenient, there'd be reasons that the leadership would fix that, because it's inherent to the things they feel are critical to their business model. Exercise was important to everybody, but wasn't critical to anybody's business model. And so as time went on, no one was overseeing it and making sure, the reports weren't coming in every month to see that it was performing to the standards that they wanted to see. And so that's where the hours just slowly drifted off, and the funding wasn't necessarily there. And so I think that's really interesting, is to think about, how do we put exercise on the map for the leaders of a business so that they have to treat it the same way they will everything else. How do we make it an inherent part of their business model? Because all of the other barriers really tied back to that. If someone cared enough, they would force the other decisions to happen. And when I say care, they obviously care, but it just, leaders have competing priorities, and this one just didn't raise the red flags that other things should. And I think one of the points that I really came to make through my thesis is, we say exercise is medicine, and I think it is as a concept from, its benefits to people, and we can demonstrate that. But exercise isn't medicine when it comes to healthcare. And I say that meaning that the systems don't actually exist to allow it to be. So if there was a new medication, we can easily insert that into our healthcare system, because we know the prescription pathway, we know the funding pathway, all of that's there. When we tried to incorporate an exercise clinic into care in a treatment center, we had to build everything from the ground up. So the referral pathway had to be built into their systems. We had to figure out how to put, the exercise programming into the medical records. We had to figure out what the exercise physiologist should be saying to the clinicians. How did they want to talk back and forth? And, everyone was open to doing it, but there was no standard plug and play. And I think that's where we need to be honest about it. And I think that's a true barrier so a business says, okay, great, we want exercise. Tell me how to do it. And the how to do it starts from the ground up. And people understandably, they don't necessarily have the money to invest in building it. And there's very few people with the expertise. We don't know the right way yet. And so that's being developed as we go. And it's really understandable that businesses are hesitant. At the end of the day, as much as we don't like to talk about the money side of healthcare, it's a reality. The business has to keep their door open. And that was one of the things that I became very clear about. We don't tend to do, when we do research, we really understandably focus on the patient outcomes. And then we say, here are really good patient outcomes. Hey, business leaders, why aren't you doing it? Well, they have business outcomes. And I think there is a bit of, if we can include these organizational leaders into our understanding of the challenges and into our building of the systems, and we understand what they need out of the programming, we can better develop programs that meet both needs. And we're not just trying to push them into a direction that just truly isn't feasible.
So if so you are saying, even though we maybe don't want to sometimes publicly say that, but we should be able to also show to the business owners that physical activity is financially also reasonable. Besides that, it is really good for the patient and beneficial for the outcomes, but it can be different from all the other medical care, so it should be included. What about the exercise specialists? I've been talking to other physicians, and I see that one of the barriers to physicians is that they don't know the exercise specialists, or they don't maybe have full trust of what's being done. And as the physicians have the responsibility for their patients, so some research shows that the better they know each other in a way, or trust, the more referrals there is. Did you see that also in your research?
Well, yes. I think the important thing about my research, so I had this really beautiful model that I got to kind of play with, which was, there was a co-located exercise clinic within a cancer treatment center that had been in existence for 4 years before I arrived. And one of the reasons that it started in the first place, it started in 2013 and really is quite ahead of its time. And it was really was born out of one of the oncologists, when they were building a new site for this cancer treatment center, had been referring his patients to the clinical trials of the Exercise Medicine Research Institute, and really he calls himself evangelical about exercise. He really bought into it and wanted all his patients to do it. So when this treatment center was open, they wanted to find a way to get all their patients access. And so that's how the co-located clinic was born. And one of the key reasons it existed and continued as well as it did was that the doctors, without a doubt, trusted, because it had that relationship. The exercise physiologists who work there were from the Exercise Medicine Research Institute. They had been trained, and the physicians, that trust gap didn't exist there. And it's one of the issues that we as an exercise field need to do a better job of, is establishing who we are and how we're credentialed, so that we eliminate some of that ability to not trust us. I think the field itself is complicated because we're not, there's a lot of different names for who we are, a personal trainer versus an exercise scientist versus an exercise physiologist. What's the right name? Who am I looking for? And then the certification process, it's complicated. And sometimes internally, we're not all on the same page. And I've been part of conversations through the American College of Sports Medicine and others, where we as a group are saying, hey, we need to establish ourselves in one clear, unified direction so we can start to close this gap a bit and have more meaningful clear direction to the doctors, because I think right now it's hard, and it's complicated by the fact they don't know the exercise professionals, partly because we're not billable. And so we have a really hard time integrating into a healthcare team, because how do you pay for us? And it's where I say, no, nobody wants to talk about money, but money is a reality. If the organization can't pay for you, then the patient has to pay for you. Somebody has to. And without being billable, it's a big problem. And it's something, in your introduction, we had just talked about cost. And again, it's not anybody's favorite topic, but it is one of the key outcomes in implementation is cost effectiveness. And I think, a call to researchers to say, when you're doing your work, try to demonstrate the cost effectiveness of the work you're doing, because we need to lobby sort of at a policy level to figure out how can we become billable? How can we be integrated? And that's a barrier that's going to exist in any country that doesn't have coverage. And it, is something that this trust gap, I think, will forever be there without figuring out how to make us a true, whether it's board certified, whatever it is, but that we can be seen the same way as a nurse would be seen, or even as a physical therapist, And
I think the trust gap, or kind of like the showing that it's cost effective, even if there is a coverage, then we still, in a country, for example, here in Finland, it is possible, but still you have to show to the policymakers that it is cost effective. So it's maybe a different part or organization to where you have to show that what you do makes sense in every way, but it's still there. I think I'd really like to ask you, before, in the second part, we will go more deeply into exercise in cancer care, what it would be like. I would really like to ask you about the feedback that you got from the different stakeholders. You had patients and oncologists, and then you had also the business owners. Is there something you'd like to bring out?
I mean, I think from the patient perspective, exercise is hugely powerful to patients. They get so much value from it. And I think it is, when we talk more about the challenges specifically in cancer, those outcomes vary widely, but just from a quality of life point of view, it's really meaningful. And there's two comments I really took away from the patients. One was, this whole process of treatment is, I listen to experts who tell me what I have to do, and they have control and I have to do it. Exercise was the one place I could take control. And I think that's very powerful, is just giving them something that they feel like they can do for themselves, because they're so reliant on just medication and things happening to them. That's one big piece of the puzzle, is giving the patient control back. The other was, so we were in a radiation treatment center. And for those that aren't familiar, radiation typically happens daily, and it, is for several weeks at a time. So it's part of the reason the co-location was so good, because they have to come every day anyway. And the consistent feedback was, it made sort of a negative experience into a positive one, because I had to go do it anyway. But then I got to go to the exercise clinic where there were other people like me, and a lot of them, which is funny, because people talk about the women often being, the social ones, but the men we saw really became social butterflies, and would go out for coffee afterwards. And that's very typical. It's not just our clinic, but it's just the power of giving somebody something good that they can do for themselves in a moment that's really difficult in many other ways is huge. So that, I think, people and, the clinicians, one of the things I really took away from them is, and it comes with the greatest care, everybody's so worried about the patient and wanting to do what's best for them. Clinicians, we have to remember, while they're educated in so many ways and are so good at what they do, often exercise is not a piece of their education. And so they bring to it their own personal bias and protection of the patient. And so often they're trying to protect the patient from something they think they won't want to do. The patient's 80 years old and she's not going to want to exercise, so I didn't offer it to her. Where in fact, and I think their vision of understanding what an exercise physiologist is going to do is not going to make the 80-year-old person run a marathon. They're going to understand what they need and give them that, and the positive that comes with that, I think, is lost sometimes. So that out of the clinicians doing the best they're doing everything they can to protect the patient. Sometimes I think we need to do a better job of getting them to understand that exercise is really powerful and potentially beneficial. So that was an interesting barrier where everyone was doing what they thought was the right thing, but not necessarily.
So even though the knowledge is there, but still sometimes, did you see that the knowledge of a healthcare provider about physical activity in cancer care was correlated to how much they referred or suggested physical activity?
I didn't measure that specifically. I think that, and it was how much across the board there. And again, because I came in several years after, the culture of exercise was already adopted. I wasn't new coming into a place. So everyone sort of knew that they should. Time was a big issue for them. So a lot of times it came down to whether or not they ran out of time in a visit. And I would say, and this is more anecdotal, I don't have the data to back it up, but it's people who did exercise themselves and really believed in it were more likely to pass it on. But that protective nature for the patient was really powerful. And you mentioned we did have issues with the clinic hours, and I thought one of the really powerful quotes was from the nurse. It said, like, why do I want to offer them something that they probably can't use? It's only open a couple hours a week. And, again, that comes back to really wanting to protect the patient. Like, I don't want to give you something you can't use and make you want it. And so that's why getting the hours more aligned with the treatment schedules was really a key part to improving the clinic.
I think you said a quote from a nurse, and I read another one from your work, which was also, I think, from a nurse probably, that you don't plant a seed unless you can water it. I think that's maybe also something we should really talk about, that many healthcare providers want to be there for the patients and want to protect them. I think it's also a really nice way to end up our first part of the podcast. Thank you, Mary, so much for being here. We will soon be back for the second part, and thank you for all the listeners.